Thank you, members of the committee. My name is David Ford. I'm the Chief Executive Officer of what's called CMA Physician Services. We're the practice transformation, practice coaching subsidiary of the California Medical Association. As we look at this issue, one important piece of federal context, and it was briefly referenced in the last panel, it has to do with H.R. 1, the reconciliation bill currently being debated in the United States Congress. Just so everyone's aware, that bill contains a provision restricting states from, quote, enforcing any law or regulation regulating artificial intelligence systems for 10 years. That 10-year moratorium in the world of generative AI seriously might as well be a millennium, because we don't really, and when we look at how fast these systems are changing and improving, imagine what it will be 10 years from now. So while we wait to see the outcome of that bill, that aside, AI really does have great promise to improve the healthcare system. It's been discussed a lot how it can handle routine administrative tasks such as documentation, patient scheduling. What's been less discussed in this hearing, it also has the ability to process absolutely incredible amounts of data that would be difficult for human researchers for the purposes of things like clinical trials and quality improvement. The challenges facing AI are very real. What Dr. Sujimoto was describing with his AIDS patient, we sometimes refer to as a hallucination. It's real, and it's something that the entire tech industry, as well as the healthcare system, is working to try to figure out to solve for. But the bigger issue, and it's been referenced many times in this hearing already, is the threat of creating AI haves and have-nots in the healthcare system. We need the large integrated medical groups, the academic medical centers, the tech companies doing what they're doing right now because it's important. They have the resources and they can. They can develop these tools, they can deploy them, they can test them. That's very important, and their resources are important to what we're doing right now. The question is how we translate that into safety net settings. Small medical practices, community health centers, critical access hospitals. I posit to you there actually are some models we could look at. I personally developed and ran a federally designated regional extension center that helped more than 10,000 providers implement their EMRs. The CalHHS data exchange framework is currently helping many providers across the state implement data exchange, and it's potential that we need to copy one of those models for AI. Thank you.
I think several of you talked about the need to be able to provide additional infrastructure support within our safety net settings and what that might look like specifically. I think you ran through three or four different things, I think combined with the sensibility around patient-centered approach to care. Those are all things that are always on our mind. Can you just rewind a little bit or highlight some of the areas where you think we would be able to make some traction in the near term, given the potential overlay of not being able to do much?
Yeah, I think we have to keep talking as though that provision doesn't pass in H.R. 1 or there's not much to talk about here, right? But so to take a step back, because I was trying to stay within my time limits, as technology has rolled out, this concern about the haves and have-nots has come up over and over again. As I mentioned, electronic medical records were very much the province of very large health systems, integrated medical groups, and then as President Obama signed the Stimulus Act and we tried to move them through the system, we found that yes, providing resources to safety net providers was important. There was a whole federal incentive program that I think we can't hold our breath and wait for at the moment. But there was also a lot of technical assistance that was provided to providers about how to choose the right system for your practice, how to implement a workflow, how to use it correctly, how to make sure you're providing better patient care. That I think was very important in how we rolled out electronic medical records in this country. And as I say, a very similar process has been taking place for the last few years. Hopefully everyone's aware under CalHHS and the data exchange framework, where we did have resources to go out and educate providers and others about why data exchange is important, how to use it, how to pick a system, how to implement it into your practice workflow. All of that matters in safety net settings.
Just build on that, my last